Hi, and thank you very much. I want to thank CFS for inviting me to give this talk, and really been enjoying the talks over the last 2 days. Some really great science. It's really been really interesting. So, I want to give a few quick introductory remarks before I start this, okay? I'm a clinician, first and foremost. I take care of patients. Very different from a lot of the science, basic science stuff that we've been hearing for 2 days. And, you know, I take care, as many of us do, these desperately ill patients ranging from 100% bedbound to mostly disabled but still able to get out of bed. and I can do a lot for them, or for most of them. They all meet the criteria for ME/CFS or long COVID. For me, that's a diagnostic label. It doesn't tell me what's wrong. It just meets the criteria. And so I look for what's going on underneath that, and I can treat a lot of that. This is something that we have put together called the CEPTAD, and we believe, and I'm convinced, that these complex illness patients have these other problems, and we can address that by treating those problems. And I can do it. We can do it. We can manage POTS. We can manage mast cell activation syndrome. We can treat small intestine bacterial overgrowth and the subsequent leaky gut, which drives disease. All of these things can be dealt with, infection especially, and yet the patients remain profoundly fatigued with PEM. And that's the holy, you know, that's the 800-pound gorilla in the room. So why do we study oxaloacetate? Full disclosure, I'm not a biochemist. I'm not a physiologist. I never even heard of this product until somebody called me about it. So this is a molecule in the Krebs cycle. And what drove the decision to move forward is a paper written by some of the people here that showed there was a deficiency or a decreased level of oxaloacetate in ME/CFS patients. And it's a fairly critical step in the Krebs cycle. So very briefly, and this is a little bit out of my wheelhouse, these are some of the things that oxaloacetate can do inside the mitochondria. But the real key here to look at is this here. Oxaloacetate, by virtue of this process, can increase or does increase NAD+ levels. It does other things which are equally important, although I think this is probably key. It actually can increase mitochondrial mass, biomass, and it can decrease inflammation by keeping that NF-kappa B out of the nucleus. So another way of looking at some of its efficacy or biochemistry, and this relates to some of the talks that were earlier today, I think it was, with respect to fatty acids, I think. And again, it's this issue with NAD and NAD+, and changing the directions of these two metabolic pathways. And as most of you know, and the patients certainly tell us all the time, a big deal is the lactate and the lactate level. I remember a study that we did with Linda Tannenbaum about 10 years ago called the Severely Ill Patient Study. And when we looked at the data, most of it I couldn't make heads or tails of, but the thing that popped out over and over was elevated lactic acid, lactate. So this process can lower that level, and that may be key to a lot of the fatigue and muscle problems that these patients experience. So this is kind of the same thing in text. This is the metabolic problem in our patients. This is the metabolic pathway Warburg effect, which is too complicated to go into right now. And the process that I showed earlier is it can reduce lactate by affecting NAD levels. Same problem in our patients, increased free radical inflammation and damage, and that can be decreased by the antioxidant potential. Oops, I didn't do that, did I? Of oxaloacetate. Again, in terms of the chronic inflammation, all of our patients, as I'm sure you know, every day they're inflamed. Even if their CRPs, C-reactive protein and sed rates are normal, they are inflamed. And that is another role that oxaloacetate may be playing. Mitochondrial dysfunction, I suspect, is a key problem in the post-exertional malaise experience for patients, and this may be another way to deal with it because it can increase the biomass. And why does that keep happening? Sorry. And then lastly, also mentioned during the talk, earlier talks, is this role of AMPK pathway, which is a key pathway in energy. And oxaloacetate is able to change that pathway and activate it in a very favorable fashion. So that was the idea behind trying it. We did an initial proof of concept trial, which some of you know about, and I presented last year. Totally bad science, not controlled, no placebo. These were pretty much my patients. I was, to be honest, very skeptical. I did not think this would work as well, but it really worked. There was a significant decrease in fatigue and improvement in the way patients felt, and the numbers were quite impressive. These are long-standing ME/CFS patients, so they're my patients. I know them well. Most of them had at least 10 years of illness. And you know, these are numbers that you don't usually see in these kinds of trials, but it was not placebo-controlled. We also did a long COVID as a separate trial. Not my patients. They were recruited from Facebook, so the follow-up was not nearly as good, but we did see some very significant benefit as well. Okay, so just as a result, a new trial was planned and has been going on for, I forgot how long it's been, but it's an 80-patient trial. It is a true RCT, placebo-controlled, out of a single center, Bateman Horne. It's 90 days, and this what I'm going to talk about now is based on the enrollment and preliminary data analysis of 40 patients. Okay, so very quickly, I think it's summarized here. The primary endpoint was how they would there be any changes in the childhood fatigue score. These are secondary endpoints, and I want to particularly point out, which I'll talk about in a minute, this endpoint here, which was discussed earlier today in some of the wearables. All patients have had blood collected and biobanked, and if the results are as good as we think they will be, then those samples will be looked at further. Okay. Not a slide you should spend time on, okay? This is just basically a quick outline of the workflow to do this study. It is a pretty rigorous workflow. Every patient is seen at the site. Again, unlike our first study, which was my patients, and I spoke to them, but they were not seen at the site on specific visit days like this, and lots of data collection. Okay, so this is, we probably, you know, I said that the primary outcome was the childhood fatigue, but I put this here because I think it's just so dramatic, okay? So this is using a device called Uptime, and I'll show you a picture in a second. Actually, let me show you the picture now. So that's the device, all right? And it's worn on the ankle. And basically, it's a way to collect data on how much time a patient spends this way versus either standing or sitting, but with their legs down. Legs out on the bed don't count, okay? And it does not include step count or anything like that. So it's missing the data of how much or what the person is doing when they're upright. But comparing upright to not upright still has great value. And as we see here, that value is pretty dramatic, okay? This is the difference between time 0 and 4 weeks later after being on oxaloacetate for 4 weeks in the treatment group versus the placebo group. Okay. All right, so this is looking at the results with the fatigue score with Chalder. And again, we see some pretty dramatic results. I want to spend a second talking about the placebo group. In the first paper and proof of concept, we made a point that one of the reasons we didn't have a placebo, or maybe it would be still useful without a placebo, is work in the past where the placebo effect in ME/CFS patients was relatively small I think it was on the order of 9 or 10%, but I don't remember. But way smaller than most other studies have seen in other kinds of patients, okay? So when I first saw this slide, this data, I said, wait a minute, what happened to our lack of placebo effect in these placebo patients? And we think it's because they knew they were in this trial, and they had heard about the trial, they had read the paper, they had seen the IA-CFS recordings or at the meeting last year, and so they had high expectations. I can't prove that, but I don't know how else to explain these dramatic improvements. I mean, I'm glad it happened, but I'm not sure I know the reason. But nevertheless, if you compare the treated patients, there's a very significant decrease in their fatigue levels. Okay, so just a quick summary. We used the 2,000 milligram a day dose, 1,000 milligrams dosed twice a day. That was sort of the sweet spot in the first study, and that's how that dose was selected. It's given usually in the morning with a meal and at lunchtime with a meal, and that's because if you take it in the evening, it may keep you awake at night. It's given with a meal because it can cause some reflux or gastritis type symptoms, and it doesn't happen if you use the meal. And this is referencing the data I showed before, a 30% increase or decrease in fatigue after being on the molecule. And same thing, and again, I have to say my favorite piece of data here is the uptime, all right? Because yes, it's great to have people say they're less fatigued, but that's manifested functionally by seeing them get out of bed and do something, or at least stand more. Okay, so moving forward, there's a bunch of trials planned or in process. We are starting a long COVID trial with similar design, although I think the dose we'll use is a little bit lower based on the previous trial I mentioned. It will also be done at Bateman Horne, and then there are some other trials going on with the use of breast cancer, not with the use of fatigue in breast cancer, excuse me, and then how it may mitigate fatigue in patients who've received radiation. And then this is one I'm particularly want to see if we can somehow pull off. I've received and read much anecdotal emails from patients, severely ill patients who say, can I please have more? This is the first time I can do anything. So that's the basis to try to do this and to use the higher dose. And as somebody asked earlier today, the question is how are we going to measure an improvement in a 100% bedbound patient? And that's kind of a challenge, but I hope we can pull this trial off. So these are some other ongoing trials. This one is in process now. I don't know how close they are to being finished. This will be imaging, which will be really interesting to see. And these other trials I mentioned. The ALS trial is in progress, and I've seen anecdotal emails from ALS patients saying, this is working, my disease is either slowed, I can do things I couldn't do before. Okay, so I don't think I need to spend much time on this. I've said it already twice, I think. It works. It has enough efficacy at the 2,000 milligram dose. It is safe. There's been no adverse effects to speak of. Chalder has been very helpful and clearly shown a decrease in fatigue. And again, physical activity has increased. Hopefully when we fully enroll and analyze the 80 patients, we'll have even more data to present.